بسم الله الرحمن الرحيم. طبعا انا بحب اشكر الاول استاذ الدكتور محمد سليم على الدعوه الجميله دي ان انا اجي واتشرف بوجودي في وسط اساتذتي وزملائي الاعزاء. وطبعا احنا النهارده يعني سيشنز، انا شايف ان سيشنز رائعه. طبعا كان معتاد ده اللي معتادينه من دكتور محمد سليم. يعني my presentation او my debates is spironolactone the best force drug with yes or no. معنا الدكتور احمد عادل المراغي assistant professor of cardiology Cairo University and دكتور امجد الشرقاوي former head of cardiology department Nasr City Insurance. اتفضل يا دكتور احمد.
مين معه ومين هو؟ الالوان باينه.
دكتور احمد عادل مع والدكتور امجد نو.
بسم الله الرحمن الرحيم. صباح الخير على حضراتكم. Thank you, Mr. Chairman. And I would like to thank the Egyptian Hypertension Society for having us today and for this great meeting. I hope this debate is up to the level of this prestigious meeting. Clearly, the question about spironolactone as the best fourth drug, it's a debatable topic, and I will adopt the pro side, and Dr. Amgad will raise a red flag against using spironolactone as the fourth drug. My rationale for using spironolactone as a fourth drug for hypertension control is that there are two hypotheses for resistant hypertension, which is not an uncommon phenomena. The first is that there is still an increased sodium load inside the body with consequent water retention. And this is because of the current regimens that you adopt using low doses of diuretics for the control of hypertension. So there must be some sodium load that's left inside the body causing the resistant hypertension. And the other thing is that there's some aldosterone excess that can contribute to this phenomena, whether it is because of adenomas or any form of primary aldosteronism. So the NICE guidelines started as a fourth step for control of blood pressure have suggested spironolactone as one of the possible drugs that could be used in addition to alpha blockers or beta blockers as the fourth drug. But the debate is still on. Dr. Amgad.
Dear friend, are you tough nut to crack? If you are not, be patient with me.
Okay.
I will not begin with side effect, but I must elaborate. Side effect of spironolactone is cumbersome, مزعجة, especially for males. We must elaborate, but this is not my rationale for no. This side effect decrease the libido, erectile dysfunction, gynecomastia, painful, and cause non-adherence. This side effect is less in female, may cause in female some menstrual irregularity, but more pronounced in male, and may lead to testicular atrophy in young age. But this is not my rationale. Your rationale, one of two: sodium retention or high aldosteronism. For sodium retention, I will say, after pathway 2, we have pathway 3. Pathway 3 say that the optimal diuretic for hypertension is uncertain. The few that low dose thiazide are maximal, avoiding metabolic consequence. كلنا عارفين ان الثيازايد بناخدها بلو دوز عشان خايفين من الهايبرجلايسيميا، خايفين من الهايبريوريسيميا. So it is improper dose, and this is a cause of sodium retention. So pathway 3 solve this problem. Added amiloride. Amiloride will have the opposite effect to hydrochlorothiazide on potassium and glucose, but same effect on blood pressure. Combination of diuretic with different site of action in the nephron will be synergistic for sodium loss and hence blood pressure reduction. Consequently, amiloride same effect in pathway 2 like in pathway 3 like pathway 2 and less side effect. The other thing, thiazide is a weak diuretic, but There is forgotten thiazide-like diuretic, chloracillidone, more effective. Duration of action more than 3 days, more sodium loss. And click trial after pathway stated that in stage 4 chronic kidney disease, chloracillidone effectively reduce systolic blood pressure about 10 millimeter within 4 weeks, which persists at 12 weeks. Reduction in urinary albumin-creatine ratio by 50%, cardioprotective. So, click trial bring a strong thiazide-like diuretic. So, if your rationale is sodium excess, I will say we have now in pathway 3 amiloride and chloracillidone.
Okay, your hypothesis is good and logic, but I have strong evidence. My evidence comes from 2 trials, randomized controlled trials, which are the best level of evidence in medicine. One of them is the aspirant extension trial, and then the pathway trial, which is a larger trial, 314 patients. The efficacy of spironolactone as a 4th drug in comparison to a placebo is marvelous. With the aspirant trial, 11% reduction in millimeters of mercury of blood pressure versus 1.7 in placebo. And in the pathway 2, they compared spironolactone with placebo and doxazosine as an alpha blocker, and bisoprolol showed that the systolic blood pressure was markedly or significantly reduced with spironolactone, much better than the rest of the drugs. And we can see that the magnitude of response is marvelous. With the spironolactone, we can see 14 millimeters of mercury reduction in the blood pressure versus only 9 with the alpha blocker and 8 with the beta blockers. So, and also in the pathway 2, we found a graded response with spironolactone. It also only used 25 to 50 milligrams per day, which means that if we increase the dose more than this, we might even get a better response with the blood pressure. We also, in the pathway 2 trial, found that the percentage of patients who achieved the target blood pressure were much higher than the placebo, and even the other drugs. Almost 60% of patients achieved the target goals of the blood pressure in the pathway 2, and 73% in the aspirant extension trial. In addition, in the pathway 2 trial, we found that the plasma renin activity modulates the effect of hypertension and the response of the drugs to the hypertension, which also might favor the hypothesis of the excess aldosterone. We found that the spironolactone was best in patients who have low plasma renin activity, which also may implicate that the sodium excess is there because the plasma renin is low, probably because of the excess sodium. Mind you that those patients are taking ACE inhibitors or ARBs and calcium channel blockers and diuretics, which are all can affect renin activity and increase the renin activity. So these patients, in spite of these drugs, still have low renin activity, which means that there is still sodium excess in their bodies. So the spironolactone acts differently and increases and decreases the blood pressure significantly with these these patients.
Oh, my friend, this slide tells us we must wake up and smell our coffee. Oh, this is blood pressure response. This blood pressure response is high with low renin. What does this mean? Means it may be hidden primary aldosteronism. The most effective dose of spironolactone with low renin. Low renin means maybe primary aldosteronism. If I give spironolactone without diagnosis, this is a big mistake. Why? Because may I mask curable condition. Maybe due to adenoma, and if I remove this adenoma, no side effect of drugs, even if it is true primary aldosteronism. This low dose of spironolactone is improper dose. we can reach 400 milligram with spironolactone in primary aldosteronism. So, when you hear hoofbeats in the forest, don't think zebra unless the talk is on primary aldosteronism. Primary aldosteronism is not a zebra. This is the distribution. This is the prevalence. Untreated normotensive, 11%. Untreated stage 1, 15%. Untreated stage 2, 21%. Resistant hypertension, which is the patient of pathway 2, 22. We مش عايزين ignore this finding. Who went to suspect pulmonary embolism? Resistant hypertension, number 1. Severe hypertension with AFib, with hypokalemia, with sleep apnea, with family history, if there is incidental tumor. So many suspicion, not zebra. Pulmonary aldosteronism is under screened. We must know that. There is many forms of pulmonary embolism, primary aldosteronism. Most common bilateral adrenal hyperplasia, aldosterone reducing adenoma. Less common unilateral adrenal hyperplasia, familial form, carcinoma, ectopic aldosterone producing tumor. And the Endocrine Society 2016 guideline stated that we must screen if sustained blood pressure 150/100 despite 3 antihypertensive or 4 antihypertensive, يعني resistant or refractory. Hypertension with hypokalemia, hypertension with adrenal nodule, hypertension with obstructive sleep apnea, hypertension with with stroke in young patient. All primary relative of patient diagnosed with primary aldosteronism. والسكريننج طبعا الدوستيرون رينين ريشيو، وفيه اولد ميثود اللي هي بلازما رينين اكتيفيتي، وفيه حاجه سيمبل ويعني سهلت الدنيا كتير اللي هي الدايركت رينين كونسنتريشن. وحقيقه لو ان احنا لقينا الحاجات دي ومش واثقين we can refer to endocrinologist. طبعا السي تي مهم، الام ار اي مش سنسيتيف قوي، بس لازم نعرف chance for possible surgical cure is our rationale not to give spironolactone blindly. طيب surgery versus medical therapy. No solid study. Generally surgery is definite. No medication side effect. طبعا احسن لو ان احنا هتبقى curable. Surgery more cost effective. Overall surgery preferred to medical if لو في experienced center، لو ان احنا عملنا adrenal vein sampling ده بيدي more confirmatory diagnosis. وهنا شفنا السلايد دي بتبين ان السيرجري بالادرينالكتومي قللت ال في ماس ذان سبيرونولاكتون. Conclusion: primary hyperaldosteronism is a prevalent, virulent, but uniquely treatable form of hypertension. Case detection should be instituted if sustained blood pressure 150/100 despite 3 or 4 drug treatment regardless of hypokalemia. Einstein قال everything should be made as simple as possible but no simpler. احنا لما بندي spironolactone blindly we are simpler. No excuse, just to do it.
Okay, I will push back against Dr. Amgad. دلوقتي هو اتكلم عن 2 points: the side effects and the primary aldosteronism. let's talk about the side effects. أول حاجة قبل side effects أنا عايز أقول pathway to trial مثلا for instance was the first study to use home blood pressure monitoring, which is a better way of controlling of blood pressure because it reduces the placebo effect and eliminates the white coat hypertension. And also the aspirant extension trial also used the ambulatory blood pressure monitor, and both of these trials use a very confident methods of screening for the blood pressure. And as for the safety, Dr. Amgad talked about the side effects. The side effects are very rare for spironolactone, and in this trial, the pathway trial, serious side effects occurred in 2% of patients only, versus 3% in bisoprolol and 2% in alpha blockers and 2% in placebo. And the total adverse effects were only 90%, but the serious ones were only 2%. Mind you that the gynecomastia, which is a very famous side effect for the spironolactone, occurs in 6% of patients only, and it was not there even in the pathway trial. As for the other problem or point, which is the primary aldosteronism, the problem is the cost. In order to do the screening and the diagnosis of primary aldosteronism, you need a lot of downstream investigations, lab tests, and you need to stop medications before doing the tests, which in a patient with uncontrolled hypertension, which is not feasible most times. And even surgery is not feasible because it is only indicated for adenomas, which are very minute proportion of patients with primary aldosteronism, which is already a rare disease. So mostly, even if you diagnose the primary aldosteronism, it will go medical with medical treatment. So the medical treatment for primary aldosteronism is still the spironolactone. So you save the patient a lot of cost along the way, and visiting a specialist in endocrinology as well. In addition, the cost of the drug itself is much less than the bisoprolol and alpha blocker, and the cost of surgical treatment for aldosteronism is even higher than the medical treatment with spironolactone. So the debate is continuous, and it's up to you to reach the decision. Thank you very much.
دكتور استاذنا دكتور سليمان عايز يقول حاجه؟
شكرا لكم عشان كل واحد عرض وجهة نظره بطريقة لائقة يعني علمية. لكن لو كان الالدوستيرون انتاجونست مش هي الفورث لاين اوف ثيرابي ما كانش اتكتبت في الجايد لاينز. Are you going to trust guidelines or not? Number 2, الديبيت دي حاجة كويسة لاستعراض المعلومات عشان نعرف وجهات النظر، وانتوا قدمتوها بمنتهى الأمانة. لكن برضو بتسيبونا احنا هل هو ينفع كفورس جايدلاينز ولا لا؟ يعني احنا بنتكلم على dependent على الجايدلاينز، هي we have to consider الالدوستيرون antagonist as a first line of therapy. اوكي؟ شكرا.
اوكي شكرا جزيلا، بنشكركم، استمتعنا بالديبيت ده جدا، شكرا جزيلا.